Hi, I'm Dr. Dan Krasalik. I'm one of the vascular surgeons here at the Vascular Institute of Chattanooga. We'll be introducing our next session. We'll be looking at chronic venous insufficiency. Spent quite a bit of time talking about peripheral arterial disease, critical limb ischemia, and wounds. Chronic venous insufficiency is also a very prevalent problem that we take care of and that you might see out in the community, and can have equally difficult time with wound development and trying to get these to heal. So our first talk today in this session will be Chronic Venous Insufficiency, Epidemiology and Economic Cost by Mary Yost. Mary Yost started her career on Wall Street as a device analyst and then went on to co-found the SAGE Group in 2002, where they looked at the time, an under-recognized problem of cardiovascular disease, and namely peripheral artery disease. She has training in economics and business that she obtained her degree from the University of California in Berkeley, and has led to extensive research of the economic and societal cost of peripheral arterial disease and critical limb ischemia, and also the cost of amputation. The following talk will be Modern Comprehensive Venous Workup by Tina Creek. Tina is our technical director at the Vascular Institute for ultrasound. She oversees 3 locations and leads a team of 10 ultrasound techs. She's been doing this for the last 4 years. She's a certified RVT, and she's also an instructor at the Chattanooga State Vascular Ultrasound Program. Following Tina's talk will be my talk on deep venous thrombosis and when to be more aggressive. I trained at St. George's University Medical School, went on to do general surgery at Western Michigan University in Kalamazoo, Michigan, and then did my vascular training in Charlotte, North Carolina. I've been at Vic for, I think, 15 or 16 months, almost 2 years. I do all aspects of vascular surgery with a big focus on aneurysm and also TCAR, which is a new treatment for carotid disease. And our last talk will be by Dr. Elizabeth Hartman on veno-occlusive syndromes, reflux disease, and advanced therapy. Dr. Hartman joined Vic after completing service in the United States Air Force as a vascular surgeon in San Antonio. She received her doctorate degree from University of Tennessee in Memphis. She did her general surgery training at UT Chattanooga and then went on to do vascular surgery fellowship at the University of Minnesota. She is both certified in general and vascular surgery. So without further ado, we'll start our next session of talks. Thank you.
Good morning. I'm going to talk about chronic venous insufficiency, epidemiology, and economic costs in the U.S. Disclosures, none that are relevant to this discussion. In 2020, if we look at the current prevalence of selected chronic diseases, what we see is that at 180 million, chronic venous disease dwarfs even diabetes at 34 million, PAD at 21 million, and all cancers put together at 17 million. Yet, chronic venous disease continues to be underestimated, underdiagnosed, and undertreated. We're going to talk about 2 aspects of chronic venous disease, varicose veins and venous ulcers. We'll start with varicose veins. U.S. prevalence is currently 54 million, and approximately 70% of those are female. Symptoms: heaviness, tiredness, tenderness, itching, aching, pain, and swelling, but this may be an asymptomatic disease. Varicose veins are not just a cosmetic problem, but a manifestation of chronic venous insufficiency, and varicose veins progress to more severe disease, including ulcers, at a 2 to 4% annual rate in low-risk patients, but in high-risk patients at a 5 to 8% annual rate. We look at current treatment patterns from the U.S. Market Scan database, a real-world database. What we see is that 70% of patients are still treated with surveillance, either with or without compression. 30% treated with some type of interventional therapy. The largest single category is laser at 10%. If we look at costs and consequences of varicose veins, a little less than 2% of treated patients develop ulcers at 1 year. At 2 years, the disease has progressed in 25% to over 40% of the patients. A high percentage need additional treatment, 55% at 2 years, and per patient treatment costs for surveillance with and without compression, $204 per year versus interventional therapies, which cost between $4,000 and about $6,000 annually. An economic case can be made for early intervention in varicose vein patients. And again, this was the US Market Scan database, and they defined early treatment as less than 2 months, intermediate was between 2 and 6 months, and late treatment was up to 24 months. And what was found was that treatment at later stages increases cost. So those treated early, the costs were $17,600 versus $18,400 for those treated late. Treatment at the later stages also results in higher disease progression. So the early treatment group, 29% of them progressed in their disease, but in the late treatment group, 52% plus progressed in their disease. Chronic venous disease, varicose veins, and DVT, there's a connection here. DVT is a risk factor for chronic venous disease. There's a history of DVT that's found in 2 to 17% of the population, the chronic venous population, and a history of DVT increases with the severity of chronic venous disease. So for example, in those with varicose veins, around 7% have a history of DVT, but in those with C4 to 6, almost 25% have a history of DVT. Turning now to venous ulcers. Annual incidence is 1 to 2 million, and the incidence increases with age. So this is very much a disease of the elderly, and particularly elderly women. Venous ulcers, current treatment costs we estimate between $21 and $46 billion. That's significantly different than the commonly quoted treatment costs of $1 to $3 billion. The difference, somewhat different incidence numbers, but the key difference is that our estimates used current US per patient treatment costs, whereas the $1 to $3 billion estimates used 1980s treatment costs in Europe. We also frequently see that venous ulcers cost between 1 and 3% of national health expenditures. If you do that calculation, that would be between 30 and 90 billion. So the 21 to 46 billion is very much in the low end of that range. If we look at the annual economic cost of incident disease, comparing venous ulcers with other types of diseases, what we see is that venous ulcers cost 38 billion versus 21 billion for treating diabetes, and 11 billion for all cancers, and 6 billion for coronary heart disease. Venous ulcers reduce productivity and increase costs. In this study, venous ulcer patients lost 40% more workdays, or 14 days per year on average, at a cost of around $2,700, and note 70% of these patients were female. Venous ulcers also reduce the quality of life. Patients view ulcer treatment as burdensome and time-consuming. They experience chronic pain, which leads to sleep loss, reduced mobility in 80 to over 90%, which leads to problems with daily living, self-care, inability to work, and inability to exercise. Odor, swelling, and discharge, all of the above has negative emotional impact, leading to fear, depression, and social isolation. And physical impairment with this disease is ranked similar to congestive heart failure and chronic lung disease. Venous ulcers have poor healing rates. At 6 months, 35% to 50% are unhealed, and at 2 years, 20% are unhealed. And poor healing increases the cost. The monthly treatment cost is approximately $2,900. So every month that goes by, then the treatment costs more. If you look at the cost of a healed ulcer versus a non-healed ulcer in this study, an unhealed ulcer cost around $38,000, but a healed ulcer cost $11,800. The EVERA trial found that early endovenous ablation results in faster ulcer healing. This was a randomized trial of 450 venous ulcer patients that compared early endovenous ablation plus compression with compression and deferred ablation, and deferred meant either after the ulcers healed or 6 months after randomization. And in the early intervention group, what they found was shorter time to ulcer healing, higher percentage of patients with healed ulcers, at a similar 1-year mean cost, around £2,500, but at significantly higher qualities. There was also a high probability, almost 90%, that this was cost effective at the conventional UK thresholds. Venous ulcers are highly recurrent. 1-year recurrence rates 20 to 40%, but 5-year recurrence rates 50%. There are risk factors for recurrence. The type of therapy, for example, compression alone without surgical correction of the underlying venous insufficiency, longer ulcer healing time, location of reflux, whether or not deep venous insufficiency is present, and the presence of PAD or rheumatoid arthritis. And recurrent ulcers cost more. Again, recurrent ulcers cost $14,300, but non-recurrent cost $11,800. Looking at comorbid PAD and the relationship with venous ulcers and the impact, we know that adequate arterial perfusion is necessary for wound healing. PAD is a risk factor for venous ulcer, non-healing, and recurrence. And PAD is very common in venous ulcer patients. Between 15% and almost 30% also have PAD, and that percent prevalence increases with age. This is an area that needs a considerable amount more research. Finally, thought it would be interesting to compare venous ulcers and diabetic foot ulcers. The incidence of venous ulcers, 2 million, diabetic foot ulcers, 1 million. Annual cost of venous ulcer, 38 billion. Annual cost of diabetic foot ulcer, 31 billion. And these are direct costs. So conclusions, at 180 million, venous disease is the most common chronic disease. Varicose veins are not just a cosmetic problem, but a serious disease progressing to more severe disease, including ulcers at a 2 to 8% annual rate. An economic case can be made for early treatment of varicose veins, that is, reduced costs and reduced disease progression. 2 million venous ulcers cost $38 billion annually. Venous ulcers reduce productivity and quality of life. Non-healing and recurrent venous ulcers add significantly to costs and poor quality of life. And finally, we need more research on costs and economics of venous disease. Thank you, 2 of my assistants.
Hi, everyone. My name is Tina Creek, and I am Clinical Director at Vascular Institute of Chattanooga, and I'm going to be talking about the ultrasound role in the diagnosis and treatment of complex venous disease. So the VIC algorithm starts once the test is ordered. Ultrasound answering the basic questions. Ultrasound is pretty much the gold standard now for imaging the lower extremity veins, but we're going to talk about why does the patient seek treatment or be referred to a vascular specialist. Sometimes they are concerned about the appearance for cosmetic reasons. They have non-specific symptoms in their legs. Sometimes they present with ropey varicose veins, blood clots, or maybe they have progressed past the point where they have skin damage, ulceration, or post-phlebitic syndrome. So talking about that, venous problems may be divided into 2 categories, acute versus chronic. The acute DVT or superficial clot could sometimes result in a pulmonary embolism, which is a complication of that acute DVT. But we're going to be talking more about the chronic effects today of venous issues. Up to 30% of these patients post DVT or SVT can have symptoms such as pain, swelling, sometimes an ulceration. And this chronic condition carries a significant morbidity. Just briefly, acute DVT, you can see here what we can diagnose on ultrasound with good flow in the artery, no color flow in the vein. It's somewhat distended intraliminal echoes. And this is just a cartoon of the thrombus here at the valve sinus. And we're also going to be talking about valve later on in the presentation. Chronic DVT, we can see on ultrasound as the thrombus ages, it becomes more hyperechoic, become attached to the vein wall, and also damage the valves, leading to venous insufficiency. A lot of times with chronic DVT, you'll see if it's doesn't recanalize, you can see a lot of collateral flow, which can lead to the diagnosis on the ultrasound of chronic DVT, but it presents as venous insufficiency. And that's what we're going to be focusing on in this talk: chronic venous insufficiency versus chronic venous valvular insufficiency. So this is a more obstructive process, secondary to DVT, leading to chronic wall changes or scarring of the vein. It can be a combination of partial obstruction and reflux, leading to venous hypertension. Or it could be a valve issue, and we can assess the valves using flow hemodynamics on the ultrasound and assessing whether or not the valves function properly. And we call that competent versus incompetent valve closure, and then also assessing the patency of the outflow veins. So we classify venous disease into these SEEP classifications, 0 through 6, 0 being no visible or palpable signs of venous disease, but we usually don't see those. SEEP1 would be telangiectasia and or reticular veins, defined as a vein with a diameter of less than 3 millimeters. We can measure that vein on ultrasound easily, and this is how the patient would present. With this information, we can give the surgeon the information that it's probably not going to be need intervention surgically. However, they can present more symptomatic with some ropey veins, leg heaviness, fatigue, itching, skin changes, which leads us to SEEP2 classification, with the definition of varicose vein being greater than 3 millimeters measured on ultrasound and presenting with these ropey varicosities. So this patient not only has a cosmetic reason to have this addressed, but they also are symptomatic. It's not just cosmetic. And the way we can assess that on ultrasound, the flow hemodynamics we can mimic with on ultrasound, the muscle contracting of the calf as the patient walks, and that muscle contracts, squeezing the vein and propelling the valve open, and all of that venous flow going to the heart. And then the valve closes and doesn't allow any backward flow going back down toward the foot away from the heart. And we can mimic that on ultrasound by squeezing the calf. This is the valve closing, and no reflux or retrograde flow back towards the foot. Or it can be, we can assess with the augmenting the calf, propelling that blood forward here at the popliteal vein level. And here you see reflux greater than 2,700 milliseconds. And we can tell the doctor this patient has deep vein insufficiency. This is just an illustration of the report that you might see. This indicating that there's reflux in the vein, and you can see, you can get the diameter measurements as well as the milliseconds of reflux in the great saphenous vein. So it's a saphenous vein origin. This patient also has a combination of great saphenous vein reflux as well as reflex here in the common femoral vein. So you've got the diameter measurement of this great saphenous vein here from the saphenous junction, saphenofemoral junction to the mid-calf, and the amount of reflex, as well as reflex in the common femoral vein. So this patient may be a candidate for EVLT. So the surgeon would go in and perform endovascular laser therapy on this GSV and maybe resolve the patient's issues of that ropey varicose vein. But sometimes the patients will present with a combination of reflux in the popliteal vein or the deep system, as well as reflux in the GSV, great saphenous vein, and present with an ulcer here. So the question is, this patient presents with C maybe 3 through 6 because they have pigmentation, eczema, lipodermatic sclerosis, and they also have an active ulcer here. So they would fall into that C category. So the VIC algorithm also includes duplex imaging of the iliocaval system. The current ultrasound technology has improved to give better imaging resolution and more depth. And so that part of the ultrasound field is evolving as to imaging these veins and the interpretation criteria once we get the images. Right now in our lab, we are measuring the diameter of the vein, reporting that in millimeters, as well as assessing the waveforms. But the interpretation criteria part of this is still being decided. But we can see that the vein measurements here in the common iliac vein are suggestive of stenosis, comparing the right side to the left with the smaller vein size on the left. So this patient had acute iliofemoral DVT diagnosed on ultrasound with no good color filling in the artery, but no color filling in this external iliac vein. This patient got a complete venous reflex workup, which means they got a combination of assessing the lower extremity veins for DVT, incompetence, whether or not the valve was, whether or not they have reflux or backward flow in the veins, as well as imaging of the iliac IVC, measuring the diameter of the vein. So they had a combination of deep and superficial venous. So they had a combination of obstructive and valve issues. So let's have a short case study here. 22-year-old female presented to the office, already been diagnosed with factor V. She had a history of multiple DVTs. She had one pregnancy, one birth. She was on Xarelto for her DVT, and she presented to the office with persistent swelling and cramping. She was diagnosed with acute DVT in the left common femoral vein. You can see these echoes here are not quite occlusive here in the common femoral vein, which is why you're getting this continuous flow signal. This was the right, much different compared to the left, with normal, no obstructive disease on the right, but a lot of obstructive disease here on the left, which imaging the iliac veins, the ultrasound showed significant compression of the external iliac and the common iliac vein here. This is with the vein on longitudinal view, the artery adjacent, and the vein very small here. So the assessment was they had extensive DVT with their history, likely scarring of the vein. Was recommended to have venogram with possible treatment using the Inari thrombectomy device. But they did have their intervention venogram that showed using IVUS, extensive left iliocaval acute on chronic DVT, and narrowing compression of the left common and external iliac vein treated with thrombectomy, venoplasty, and stenting of the common and external iliac vein as well as the common femoral vein. These are just the images from that intervention. You can see here a lot of collateral flow with no iliac vein flow here, but all the flow going out through the right iliac vein system being dominant. And this is just another huge collateral trying to empty the flow out of that leg. Post venoplasty and stenting and thrombectomy, you've got really good flow on the right and the left, and all those collaterals are now gone. They presented to the office with a follow-up ultrasound that still showed narrowing of the IVC and some in-stent stenosis. The stents imaged really well on ultrasound. So why the no echoes in the external iliac, IVC, somewhat small measurement, and they did show some in-stent restenosis in the common iliac vein in the stent. So this is the long view, and this is just a transverse view of, so you've got reduced color filling in the vein. But even with that, the patient said she was walking up to 2 miles a day, denied swelling, pain had resolved, still continuing her Xarelto. Thank you.
I'm Dr. Daniel Krasalik. My talk today will be on deep venous thrombosis and when to be more aggressive. I'm a vascular surgeon at the Vascular Institute of Chattanooga. So VT represents a serious medical problem that can include pulmonary embolism and deep vein thrombosis. DVTs of the legs can be divided into 3 types: those involving the calf below the knee joint, those that are more proximal but below the inguinal ligament, and those that are extend even more proximal in the iliofemoral segment above the inguinal ligament. This classification is important because as you move more proximally up the leg, the incidence of PE, development of post-thrombotic syndrome, and treatment approaches vary. In-hospital mortality for VTE approaches 12%, and it represents one of the #1 preventable causes of in-hospital mortality. In a given year, there's over 600,000 non-fatal VTE events and almost 300,000 VT-related deaths that occur. So you make the diagnosis of a DVT, what should you do? So initial therapy is anticoagulation. Anticoagulation should be started as soon as the diagnosis is made. Traditionally, in the in-hospital setting, treatment starts with either intravenous heparin or subcutaneous low molecular heparin, such as Lovenox, and then bridge to a vitamin K agent such as warfarin. This usually takes 5 to 10 days and can eat up a lot of resources at the hospital. Unfractionated heparin on itself, effective for anticoagulation, however, takes in-hospital setting for titration to meet the PTT goals you need for therapeutic ranges. It also has an unpredictable pharmacodynamics and narrow therapeutic window. So a good agent, but not ideal agent. Low molecular heparins have proven to be a little bit better as far as treatment for DVT, especially in an outpatient setting. There's better bioavailability, they're more consistent response and more predictable. They don't require as frequent monitoring, just need to monitor the platelet count, and these can be given once or twice daily for weight-based dosing. And we have the newer oral anticoagulation agents that don't require frequent laboratory monitoring, and they have good efficacy and safety profiles. There's 2 direct factor 10A inhibitors, Xarelto, Eliquis, and then you have a direct thrombin inhibitor in Pradaxa. Another thing is Traditionally, in the past, we've recommended that patients be on bed rest and try to elevate the legs and minimize mobility. However, this has been debunked in recent literature. And studies actually show that pain and swelling improve more quickly in those that start early ambulation and compression compared to those on bed rest alone. Another kind of a controversial topic, or topic that part of DVT that a lot of people kind of get confused by, is treatment for calf deep vein thrombosis. Those DVTs isolated to the calf on their own, it's hard to decide what to do with those. Some studies show that 15% of these will extend more proximally if left untreated. Latest ACCP guidelines suggest serial duplex imaging of the deep veins over initiating anticoagulation in patients that are asymptomatic or with minimal symptoms and have low risk factors for extension. In patients that have more severe symptoms or have risk factors such as a clotting disorder, recommend initial anticoagulation as you would for a more proximal DVT. Optimal duration of anticoagulation still kind of remains a controversy. You want to place patients on anticoagulation long enough to take care of the problem and reduce recurrent DVTs, but at the same time reduce risks for bleeding, namely bleeding risk is about 1 to 3% per year. Current ACCP guidelines recommend anticoagulation to be continued for at least 3 months for patients for their first episode of idiopathic DVT or PE without an excessive risk of bleeding. When anticoagulation is stopped, it's recommended that the patient be placed on an aspirin to prevent recurrent thrombosis if they don't have a contraindication for that. So most dreaded complication of DVT long-term is the post-thrombotic syndrome, because this carries severe morbidity and reduces patients' overall quality of life. This results from valve incompetence that causes venous hypertension down the leg. The severity of the patient's acute DVT is predictive of post-thrombotic morbidity, especially when it involves the iliofemoral segment. It's just an illustration showing the pathophysiology of the development of post-thrombotic syndrome. Multiple studies have shown that patients with PTS have worse quality of life than those with chronic lung disease, arthritis, or diabetes. About 5 to 10% of patients that have a symptomatic DVT will develop the most severe form, PTS, that's characterized by severe pain, chronic ulcerations, stasis dermatitis, venous claudication, and intractable edema. And their quality of life is that with those with end-stage cancer and heart failure. Just pictures showing initial presentation with swelling of the leg, and then after 1 and 2 years, progression of their venous hypertension and ulcerations that have developed. So rationale for thrombus removal, there's a large body of evidence supporting the rationale for strategy for thrombus removal, especially in those with iliofemoral DVTs. When successful, venous patency is restored, you maintain the valve function, quality of life is improved, and risk for recurrence is also reduced. One of the bigger trials, the CAVENT trial, enrolled 609 patients with iliofemoral DVTs and randomized them to medication or procedure for intervention, and looked at patency at 6 months and also development of PTS at 2 years. Those that received a catheter-directed intervention had a clot resolution of 82%. They had improved iliofemoral venous patency and also had less PTS development at 2 years. The absolute risk reduction with those that underwent intervention approached 15%, and major bleeding occurred in 3% of those patients. More recently, the ATTRACT trial was a multi-center randomized trial, nearly 700 patients with leg DVT. They were randomized to either anticoagulation or anticoagulation plus therapeutic intervention. The primary outcome they looked at was development of PTS between 6 and 24 months. They saw no significant difference in percentage of patients that develop PTS between the two groups. The intervention arm had more episodes of major bleeding compared to those just on anticoagulation, and there was no significant difference in recurrence of venous thrombosis between the two groups. Moderate to severe PTS occurred in about 18% of patients that underwent intervention compared to 24% in the anticoagulation arm. Severity scores were lower in the intervention arm, however, did not equate to improved quality of life at 2 years. One of the biggest problems with the ATTRACT trials, they lumped in the femoral popliteal patients with the iliofemoral patients. Other studies have shown that really the people that benefit the most for intervention up front is those with the iliofemoral DVTs over those femoral popliteal DVTs. So that has kind of skewed some of that data. Also, the devices that we use to clear clot now weren't widely available during the study period, and we have more advances within the technology to clear clot more effectively. Also, they didn't have IVUS available, which is intravascular ultrasound, which is kind of a mainstay in treating patients with venous disease to evaluate up front, and then also to determine if adequate thrombectomy has been performed to clear the acute clot in these patients. So catheter-directed therapy be first-line treatment in all proximal DVT patients? No, it shouldn't. It really is a salvage procedure for patients with moderate to severe symptoms and the younger, healthier, more active population, those kind of with end-stage medical diseases that limit their overall physical ability, they're debilitated. Those type of patients would not benefit, but the younger ones definitely see benefit with intervention up front to try to maintain valve function and mitigate the risk for PTS development. So catheter-directed thrombolysis, this is literally putting a catheter within the thrombus and instilling TPA over a period of time, typically 24 to 48 hours. Bleeding risk, anywhere from 5 to 10% with this procedure, mostly are at the access site. To start intervention, symptomatic PE as a cause from the procedure is relatively low, less than 1%. And most reports show a good or excellent lytic response that reduce the overall clot burden and maintain valve function and mitigate reflux. Pharmacomechanical thrombolysis is the act of physically removing thrombus from the affected vein. One of the catheters that we've had around for a while is the AngioJet. This is a thin catheter. It sprays heparinized saline out to create a vacuum that causes hemolysis of the clot, and then that's sucked back up. You can instill TPA in prior to doing this. By doing this, you reduce the treatment time and also the length of hospital stay. The only downside really for this intervention is it does cause hemoglobinuria, and in those patients with baseline kidney disease, this can worsen with this intervention. Just a picture of this within thrombus. You also have some large bore suction thrombectomy catheters, as you can see here. One of the well-known ones is Penumbra. They just came out with their large 12 French device. This is very useful after instilling TPA where the clot is softened up, and you just put this in to perform essentially percutaneous suction thrombectomy to remove the overall clot. And then more recently, Inari Clot Retriever. This is a mechanical device that you insert in through the popliteal vein, and actually this basket down here opens up and you physically drag this down to remove the overall clot. Nice thing with this is that you don't need to do the TPA. They don't need to stay in the ICU. It's a one and done type of procedure. And you can see the amount of clot that's able to be removed with this intervention. So based on published guidelines, management of iliofemoral DVT with catheter-directed or pharmacomechanical directed therapies is reasonable as a first-line treatment for iliofemoral DVTs in the select patients, like I mentioned above. Systemic fibrinolysis is not indicated, and then stent placement for treating underlying lesions is appropriate. So just to end with a case of mine, 30s male presented with bilateral lower extremity swelling. He had to leave work because it was so severe. Presented ER, found to have bilateral iliac vein DVTs. He was starting on heparin, taken for a venogram. You can see the lack of opacification of contrast within these veins here. You don't even see the inferior vena cava. He underwent overnight thrombolysis, percutaneous mechanical thrombectomy, removed residual clot, and then reconstruction of the distal IVC. and iliac veins with stents. He's been seen in 6-month follow-up, and he is free from all symptoms prior, no signs of PTS. This is the end of my lecture. Thank you for listening.
Good afternoon. My name is Elizabeth Hartman, and I'm a vascular surgeon at the Vascular Institute of Chattanooga. And this session is going to be about veno-occlusive syndromes, reflux disease, and advanced therapies. So some people have mentioned in this session that venous reflux disease is at least 2 times more prevalent than coronary artery disease and about 5 times more prevalent than peripheral arterial disease that we treat mostly. And over 30 million Americans are affected with venous reflux disease. However, a very small fraction of those actually seek treatment on an annual basis. Risk factors, as we've gone over previously: gender, age, family history, being pregnant, having injury or surgery, a standing occupation, and obesity. And the symptoms can be pretty classic or they can be pretty atypical. You can have anywhere from pain or aching in the legs, cramps, burning, itching, swelling, feeling of heaviness in the legs, and then skin discoloration, open wounds, and visible veins are very apparent on physical exam. The picture just shows a typical normal valve in the vein, which are present in both deep and superficial venous systems of the legs. In a healthy vein, the valves open and close, but in a refluxing vein, the valves are stretched out, the vein is dilated, and you have a reflux of blood through the valves, increasing the venous pressure of the leg. So the SEEP classification is a classification system we use to classify how advanced the disease process is in patients. Class 3 through 6, patients usually have pain. Sometimes they get painless edema, but a lot of patients, when they get this advanced, do present with pain. You can have asymptomatic and symptomatic varicose veins in type 2, but usually when it gets to 3 and above, we may need to perform a surgical intervention. One of the first steps we perform in patients when they present to us, we do a venous reflux study to include the pelvic veins, which is very important to look for these occlusive syndromes that can be present, causing venous reflux to be found at the common femoral level. So we look higher and we measure the diameters between the right and left common iliac veins and external iliac veins, and we also look at the IVC. We look at the waveforms. We look for any stenosis, and we measure these. And so this gives us a good idea if the patient is a candidate for venogram or endovascular intervention for their deep system. So surgical therapies for veno-occlusive diseases to include May-Thurner syndrome, which is an anatomic compression of the left common iliac vein by the right common iliac artery. This can also be seen in the right side as well, but mainly in the left. The picture to your right simply shows a kind of a chronic obstruction of that left common iliac vein. The veins you see crossing the midline are the collateral systems. And then once this was able to be treated with a venous stent, you can see the drainage of that left leg is significantly improved over prior. And this is most likely a post-thrombotic syndrome, which can happen when the patients have iliofemoral DVTs. Simply treated with anticoagulation, they can get this scarring in the veins and then have obstructive symptoms that need to be treated. We also treat symptomatic reflux in the superficial system in both legs with surgical therapies. And this would be in the lesser and greater saphenous veins. We can perform laser ablation. We can also perform venous seal, which is a glue that we can place in the vein that seals the vein off. And this is basically getting rid of that superficial system that's refluxing to improve the patient's systems. So in addition to the superficial venous therapies, we can perform deep venous therapies. And these are mainly starting out with a venogram to diagnose the problem. We'll have an ultrasound going into it. We'll know kind of what we're looking at, but with the venous system, we're looking at the iliac veins. We measure that diameter with IVUS. We look at both the right and left sides. Sometimes we'll have to focus based on what the ultrasound is showing us. You can see the pictures to the right. The left common iliac vein only had about a 37% stenosis based on IVUS, but the external iliac vein had about an 80% stenosis. This was treated with a venous stent with good result. So we're going to go over a quick case here just to kind of give you a sense of how we treat patients. This was a fairly advanced case. This was a 64-year-old gentleman that came in with some history of aortic ectasia, which is this dilation of the aorta, some iliac dilation. But he reported claudication symptoms, increased swelling and pain when he ambulated, feeling of pressure in his legs. He also had some weeping fluid at the ankle level from a wound. He had some discoloration in his toes and feet. He did have a previous history of DVT and pulmonary embolus. He was on chronic anticoagulation. On physical exam, his arterial system was normal, but he did have venous stasis changes to include telangiectasias of the lower legs, hemosiderin staining or hyperpigmentation of the left leg. So his ultrasound was completed looking at the most superficial and deep systems of the legs as well as the iliac veins, and you can see he had bilateral common femoral vein reflux, and this can be an indicator that something higher is going on. So we looked at his iliac veins. He had some differentiation between the diameters to right and left. This gave us an indication that he may have a occlusive syndrome of higher causing this deep venous reflux in his legs. He did have some superficial reflux in the greater saphenous vein, but it was isolated to below the knee. So he underwent a venogram. This demonstrates on the right of intravascular ultrasound picture measuring the diameter between the normal common iliac vein and the abnormal or the most stenotic area of the common iliac vein. And he had about an 80% blockage of the left side. On the right, we also performed IVUS and venography. He had about a 70% lesion over here. It is important when patients have bilateral iliac vein stenosis that they get kissing iliac stents, because these stents have a very strong radial force. And if you have one stent that's not landed perfectly in line with the other side, they can have overriding stents and causing compression of one side or the other, which can lead to continued symptoms. So the picture on the right is post-stent. The IVUS catheter is in one side of the stent, showing the equal diameters of both stents, how they're not competing, and they have treated the stenoses. There's the common iliac vein bifurcation. You can see the area of compression kind of overlying that left common iliac vein and onto the right, and then kissing stents that were equal in length. So postoperatively, he did very well. He had no more weeping fluid from his leg. He had no pain. His walking was improved. He basically had no symptoms. He was going to be maintained on his anticoagulation because of history of PE and DVT. And on ultrasound, the diameters were roughly equal bilaterally. And this is important. We bring these patients back to at least every year to look at their venous stents, because they can develop some chronic scarring or tissue inside those stents, and we just wanted to make sure they did redevelop symptoms in the future. So in conclusion, chronic venous insufficiency affects many Americans. Very few of them present for treatment, but when they do, we can use ultrasound as a first-line therapy to determine if there's deep venous occlusive disease, as May-Thurner, post-thrombotic syndrome, or if it's simply a superficial system that can be treated with ablation. So after identifying that, we can perform on an outpatient basis either a venous ablation, venogram, IVUS if needed, stenting, balloon angioplasty, and these can greatly improve a patient's quality of life after suffering from venous insufficiency symptoms for a long period of time. Thank you very much.